Bismillahirrahmanirrahim. I'm really thankful to Professor Javed Akram and the organizers of the conference to give me this opportunity to be with my colleagues from internal medicine. As I had the opportunity to serve at all sister medical institutes in Lahore, Allama Iqbal Medical College, Fatima Jinnah, and for much longer period, King Edward Medical College and then university, I honestly cherish my memories to see my colleagues wonderfully progressing well from the platform of internal medicine. As a poet said, किसी हमदमे दरीना से मिलना आदम बेहतर है मुलाकात मसीह और खिज़र से. It's so cherishing for one to meet with colleagues for whom we haven't met for a period of time, over a period of time, but it's really honor to again relive with the same memories. My brief talk for today would be psychiatry for the non-psychiatrists. I am fully aware that most of you have a great burden of psychiatric morbidity in your clinics, and I'm sure you're treating most of these cases suffering from depressive disorder in your very busy practice. So it would be very right to say that depressive disorder or major depression is a highly prevalent disorder. It is chronic, it is recurrent, and it is progressive. That's how we need to pay more attention to this particular psychiatric morbidity. As you see in this slide, that this disease burden of depression is not unique to any country. Rather, it is all over the world, almost the same figures. If we take prevalence of mental disorder in Europe from 2011, we see that major depression ranks at number 2 in its incidence other than anxiety disorder. So we can well imagine that this is a problem which is ever increasing, and WHO says by 2030 perhaps it would surpass all other diseases as a global disease burden. So that's how we need to pay attention, because those who suffer from major depression, they feel sad, they feel dejected, and they feel empty inside. So we need to do something for this lot. Depression, of course, is the leading cause of disability worldwide, and it's a major contributor to the overall global burden of disease. I'm sure what Professor Negat Mir was saying, even among majority of her cases, this disorder would be on surface at some point. As we see that major depressive disorder is the leading cause of the disease burden, and if we go into the list of these disorders, like lower back pain, major depression is at number 2, and then other physical ailments like iron deficiency anemia, neck pain, COPD, etc. So again, we need to see that this is a problem which is there, and we need to do something about it. This burden is associated with the large and increasing suffering for the community at large. Depression is again one of the leading causes of disease burden in comparison to the other major psychiatric disorders like bipolar disorder, alcohol abuse, and schizophrenia. It has a detrimental effect on overall health. As you see from this slide, that it affects almost most of our domains of our life, and it makes our survival rather more difficult for us. It is associated with a significant personal and social consequences as well. So this would entail to different areas and it makes things difficult for the patient. Sometimes we could have mild to moderate symptoms, but we would only say that when the symptoms are severe enough and when they tend to persist over a period of time in such a way that they interfere with a day-to-day life functioning, then we would say that at that point perhaps we need to intervene. It has significant cost to the society at large, because those who suffer with major depressive disorder, many a times they are unable to go back to work, they are unable to attend to their social duties, they are unable to perform well even in their domestic sphere. So it has a global impact, overall impact on their working, and makes them to suffer. And then as a result, the society at large suffers as well. It is associated with great economic cost as well, as you see in this slide, that billions of dollars are being wasted due to this disorder prevailing. If we could do something in time for prevention and then cure, as we see majority of those cases who suffer with major depressive disorder, even if they are given one single antidepressant by either physician or psychiatrist or any other medical practitioner, then 70 to 80% patients, they do recover. So in this era of scientific development, there should be no excuse that why somebody should persist with this disorder of major disorder. The only question is that at what stage or point we tend to diagnose them and to offer them the rightest medication. Again, in this slide, this shows that per patient, the mental disorder in Europe, what was the cost like. So we don't need to go into the details of this, but the loud message is that it makes the society at large to suffer, and they have to pay very heavily for this disorder. It affects directly their working time of the patient population who should have been at work. Most of them, they are absent from their work, for that matter. We need to bear in mind certain signs and symptoms before we say that we could diagnose this disorder, and we should take into consideration certain symptoms from these three criteria, like DSM-4, DSM-5, or ICD-10. More or less, most of these patients, they present the same list of the symptoms when they suffer from major depressive disorder. Briefly to mention that these symptoms could be depressed mood, anhedonia, significant weight changes, especially weight loss, sleep disorders, especially early morning awakening, psychomotor retardation, fatigue, feeling worthlessness, and most of them, they feel guilty as well, with cognitive dysfunction, thoughts of death, and self-confidence and self-esteem problems, because they feel very much low in their self-esteem and in their self-confidence as well. We know with certainty that these sufferers of major depressive disorder, if they are not diagnosed and treated, unfortunately, 10% of these cases, they do commit suicide as well. Again, that is a life loss which is utterly preventable, and it is far greater than the life loss as a result of road traffic accidents. So, in majority of these cases, these symptoms, they appear quite evidently, like depressed mood, anhedonia, weight change, sleep disturbances, agitation. In elderly, it could be rather retardation. And younger population, they do present with more of agitation. Fatigue is there. Among the cognitive dysfunction, we know that, again, some symptoms would be bothering our patient population towards their recovery. It leads to functional impairment. And that functional impairment pertains to their work, their social life and leisure activities, their family life and home responsibilities, interpersonal relationships as well. So this is a disorder which makes you really handicapped in most of the spheres of your day-to-day functioning for that matter. Now, what are the certain definitions of treatment success in depression? We reckon that once the patient they start showing response, then according to Hamilton Anxiety and Depression Scale, if they have shown response, symptoms have been relieved up to 60% or so, we would say that the patient has shown good response. Once the symptoms, majority of the symptoms have disappeared, then we would say that the patient has gone into remission, and they tend to remain in remission in between each episode because it is a recurrent disorder. So in between, they remain in remission and continue to perform well. But what we should be aiming for would be full functional recovery. What we mean by that majority of the patients, they were showing good response to most of the antidepressants in the spheres of somatic symptoms and emotional symptoms. But there were not many antidepressants before which were having impact on the cognitive symptoms as well, like poor attention and concentration, forgetfulness, and indecisiveness. For these three symptoms pertaining to cognitive sphere, our newer antidepressants like vortioxetine does have their impact, and in a way they help the patient to recover and to not only seek remission but also to gain full functional recovery for that matter. Now, depression can be evaluated from different perspectives, either from patient's perspective. He would say that if his depressed mood is elevated, physician's perspective, once they feel that their patient is showing response to most of the symptoms which they were presenting to begin with, and from clinical study perspective where they reckon that they would be showing improvement on certain scales. So what is the mainline clinical course and treatment outcome? As you see that as we start treating the patients, they could show response, then they could go into remission, but then unfortunately again they go into recurrence sometimes. They go into relapse, and these relapses could become recurrent as well till they gain full functional recovery. How to treat such patients suffering from major depressive disorder? Of course, we would take some help from non-pharmacological interventions like behavioral therapy, interpersonal therapy, group therapy, cognitive behavioral therapy, and these days we are stressing more on the mindfulness-based cognitive therapy. This is an area where perhaps you as physicians may not have much time and expertise, so better to leave this with the clinical psychologists and psychiatrists to help the patient in these areas, like on the basis of these non-pharmacological measures. But of course, we depend a lot on antidepressants. Now, antidepressants pertain to different classes and groups. Most widely prescribed antidepressants these days pertain to SSRI group, serotonin specific reuptake inhibitors. I'm sure you're using a lot of these SSRIs, especially escitalopram and vortioxetine these days. There are other groups as well, like we would say SNRI and certain atypical antidepressants as well. So whatever we pick and choose, we could either use as monotherapy, or we could use in patients who fail to respond fully after 8 or 12 weeks or so. Then we could go for adjunctive treatment, and that could be in the shape of another antidepressant, or we could add one of the non-antidepressant like small doses of major tranquilizers. Or we could offer combination therapy to these patients. Our guidelines for these treating these patients, that they come into 3 groups like mild, moderate, and severe. The group which pertain to severe MDD, they are the ones who are most at risk to unfortunately commit suicide or to have very strong suicidal ideation if they remain untreated. So for some of these cases, we may have to offer electroconvulsive therapy, ECT, as an inpatient treatment. Or even if we feel that the symptoms are such that the patient may not show much response at home or on outdoor basis, then inpatient treatment in any psychiatric setup would be recommended. For that matter, this is just a meta-analysis of certain studies showing efficacy, comparison of various antidepressant groups. As I told you that the symptoms belong to three main areas like somatic, emotional, and cognitive. So one particular compound which is available now luckily, vortioxetine, which is more or less similar in efficacy in other two areas, but it has advantage in the cognitive dysfunction symptoms like, so it could help us to make our patients gain full functional recovery for that matter. So thank you very much for your kind attention. Thank you.